So the MAINTAIN trial wanted to address the value of maintenance after induction treatment with bendamustine rituximab. And the rationale, of course, was because there was no data available when we started the study, giving us some information if BR followed by maintenance is meaningful or not. And in 2008, when we designed the study, everybody was expecting the results from the PRIMA study, and we already anticipated that maintenance improves progression-free survival, and it was atmosphere and expectation in the community that maintenance is very important. Even in these days, everybody believed if you give a lot of rituximab maintenance, maybe you can even cure the disease. This was a hypothesis and the belief, or as we can say retrospectively, the big hope that with more rituximab you achieve more efficacy and maybe some cure. So then we wanted to do a large randomized trial. I myself was proposing the randomization between bendamustine rituximab against bendamustine rituximab plus 2 years, because we did not have any data for this important question. However, as I just mentioned, the community in Germany, participating study sites of my study group, they all discussed it, and opinion was great idea, but all clinicians want to have maintenance, even if it will be absolutely good after BR. So we want to have maintenance. And then after a long debate, we decided to do BR plus 2 years against BR plus 4 years, which is retrospectively maybe not the most relevant question, because 8-9 years later, we have some more knowledge, and we think the most critical question is if maintenance at all after BR is good or not. So we decided to make this design, and then it becomes a little bit more complex, because you have to answer the question, when do we randomize the patients? And we debated it and we discussed it with statisticians, and it was very clear we can only randomize this question when we have used for every patient bendamustine rituximab plus 2-year maintenance. Only then we make the randomization between 2 more years, which is a 4-year arm, or no more treatment, which is a 2-year arm. The primary objective was the comparison between 4 and 2 years. I showed the results. The results looks excellent in favor of 4-year maintenance. However, this difference with a hazard ratio of 0.73 was not statistically significant. The p-value with a one-sided test was 0.11. Why it was not statistically significant with a hazard ratio of 0.73? Because we saw much less events than expected. After the 2 years, when we randomized for 2 more years on just observation, we observed 26 or 33 events in either arm. And that is much better than we expected. And that is a reason, probably the reason, why it was not statistically significant. So we see a trend when you look at the curves. The 4-year curve looks better, but this is not statistically significant. And the other very important objective was to compare it historically to the NHL1 trial. And with that, we included all patients from NHL7, even the patients, of course, who have not responded, even the patients who have stopped early during the first 2-year maintenance because of some toxicity events or progression or something else, and then compared it to NHL1. The one thing is what we did, we censored the patients who were randomized to 4 years at the time of randomization, to make it very clear that we only look for the patients who have had 2-year maintenance. And when we did this, the results were clearly in favor of the maintenance after BR, highly statistically significant with a p-value of 0.007. So it was a clear result in a cross-study comparison with all the limitation of such a non-randomized comparison. Maintenance after BR was prolonging progression-free survival. It's always a debate what is the best endpoint for such a disease. And I know many colleagues, they told me, perfect study, it shows that maintenance is very good after BR. You achieved a better progression-free survival. And then you wait 5 minutes, you walk through the meeting, you see another colleague and he tells you, perfect, I understand that maintenance is not meaningful at all because the overall survival was not changed. So it's good for everybody, more or less. It just depends on how you look to the endpoint, if you think progression-free or overall survival is the most important endpoint. What is important that we also reported, the toxicity was not so high as maybe some have speculated. But why is that the case when we remember the gallium trial and other trials who reported a lot of toxicity? I think because in our study it is a very meaningful clinical management, because we selected out the patients during the first 2-year maintenance who may be not suitable for a long ongoing maintenance. When you have some neutropenia in the first 2 years, according to just rituximab maintenance, we stopped it. When you have a severe infection, we stopped it. When you have some progression, of course, again, no randomization will be done. But also some other comorbidities and, interestingly, patient's decision. Some patients feel exhausted, tired, they have fatigue, and they withdrawn their informed consent. This was 15% of the 261 patients who were not randomized. That's a large cohort of patients, but this is, as I know from my experience, the real world. Some patients really prefer to go on with maintenance, and they feel safe, they have no side effects, they feel comfortable, and they feel this is very important for my ongoing remission. Some other patients on the side say, discuss with me, doctor, do we need it again? I have an ongoing remission, always after rituximab, I feel tired. And I realized that some patients, when they come to me every 2 months for the rituximab, told me that after every rituximab infusion, they went to the family doctor and they got some antibiotics, and they were not able to go for work for 1 week because they feel tired and exhausted and not fit enough. So this is, of course, not the meaning of a treatment in an ongoing remission, that suddenly you feel sick due to an infusion. So these patients probably were the patients who said, I don't want it, because you face the future randomization where you even could go to the arm with 2 more years. This was probably the reason that some patients said, no, I don't want to go so far. And all these patients were excluded from randomization. And during the first 2 years of maintenance, where this all was decided, the median of administered rituximab cycles was 6 instead of 12. So that means all the patients with these toxic events or not feeling very well and the patients are not motivated to continue, were taken out quite early. In the other trials, which we know from the literature, the randomization was done immediately at the beginning of treatment. And when you then have some toxic event, probably the protocol says, okay, we have to treat the toxic event, but you have to continue with the maintenance. And maybe then you run into some very severe complications. So I think, as in general, in real world, you start maintenance, but when the patient has some signal of safety and toxicity, or maybe it does not feel motivated, it's no risk to stop early because you probably prevent some severe complications. But the patients who are fit enough to continue, they have a benefit from the maintenance.